Yes, absolutely. Yes. So I'm Lorena Wright. I am an adult endocrinologist, and I spent most of my time at the Diabetes Institute. And I also have clinic in Harborview and Roosevelt and the endocrine clinic, where I do exclusively gender affirming care. Maybe I met some of you because some of you have rotated in this clinic, or I will see you. Hopefully you have a chance to rotate in our clinic. And yeah, so let me know when you want me to start.
I think we can go ahead and get rolling.
Okay, great. Very good. So I don't have any conflicts of interest, and I'm going to be using, AHD a lot. That's gender affirming hormonal therapy. And as you know, the transgender community, LGBTQ community, is an underserved community. So, they've been bear the brunt of social and economic marginalization due to their gender identity. So being aware of these challenges and the challenges that our patients face can markedly improve how effective our treatments are, and how follow-ups and trust, etc. These are the general principles of taking care of transgender patients. And I think like in general, so we want to empower patients, we want to be inclusive. Not only we support them, but we also need to work against stigma, and we want to facilitate access to healthcare. We need to respect diversity. It is not a good idea to pathologize the differences in gender identity, right? It's not a pathology. And we all, respect, we all deserve freedom of discrimination, and we all have the right to the highest attainable standard of health. So when treating our patients, just remember that we want our patients to be as healthy as they can be and as happy as they can be as well. It is very rewarding to take care of this patient. It's a privilege. So, I think the fact that you're here learning about this makes me very happy. And we have a lot to learn, but being humble is very important. So the objectives, gender affirming hormonal therapy is really individualized. It needs to be customized, including for non-binary identities. I think that's part of what I really love about taking care of trans patients. That is really a spectrum. It's very clinical. You need to have relationships with patients. So I think that's the beauty of clinical medicine. So we adapt because we don't have, as much research as we would love to have. Then we need to adapt principles and apply the knowledge that we know from other scenarios and other populations. Sometimes it's not ideal, right? But we need to use physiology, use perhaps other studies, use our judgment, discuss with our patients, and to have effective, safe interventions. And then we also need to talk to the patients about the risk of low sex hormone levels, which can happen in non-binary patients. I won't really have time to review everything that I would love to, right? But because this is very extensive subject, but I try to focus on pearls, on questions that my patients have had that at times were challenging, like I didn't know how to answer those questions, or we didn't have research, or we have research but very little. So I'm hoping that the cases that I chose, will be pretty informative, and that you will learn from this. As I said, right, like gender is on a spectrum, it's part of the beauty of being human beings. And then it's important to know where our patients, are in this spectrum, because then that will help us individualize the treatment. So I will start with Jackie. Jackie is a 45-year-old adult, assigned male at birth, with a female gender identity. And she experienced gender dysphoria more pronounced 2 years after she had a left orchiectomy for a testicular mass that turned out to be benign. She was recommended to start testosterone, but that made her feel really, really bad and caused suicidal thoughts. She can explore a little more her gender identity that she had suppressed for a long time. And then, decided to see a transgender specialist. She was started on estradiol at a dose of 0.5 milligrams sublingual twice a day. That's kind of like a low dose, but that's what she was on when I met her, or she had been in the past. So she then underwent gender-affirming Wright orchiectomy 12 months later after being on, estradiol for a year. But 5 days after the orchiectomy, she had chest pain, and she ended up in the hospital with a diagnosis of non-STEMI. She, had appropriate care. Her past medical history, BMI is 31. She has a history of diabetes that is poorly controlled with an A1C of 8. Hypertension, hyperlipidemia, no family history of premature cardiovascular disease. And she had already been on atorvastatin for many years because of her diabetes. So because of this cardiovascular event, estradiol was stopped, and her provider felt very uncomfortable about resuming estradiol. So she's here, to discuss AHD. So what did you recommend? Right, she's here to talk about that. So did you resume sublingual estradiol? Did you switch to transdermal estradiol? Did you switch to oral estradiol or parental estradiol? Or do you feel kind of uncomfortable about that? Maybe we'll just start spironolactone first because of the recent cardiovascular event, and then we'll add estradiol later. Can't really see you, right? But just think about it, and then if you want to, write in the chat or tell me what you would do, go ahead. Otherwise, we can, I will discuss, each of the options with you.
Dr. Wright, I can also launch kind of a general poll that's just like A, B, C, D, E. Would that be?
Sure, if that's possible, yeah.
Let's
That's
try
possible.
it. Okay.
That'd be cool. So I will get back to the answer later. So then we are going to learn about, oops, what am I doing here? Okay. We're going to talk about cardiovascular health. Okay, so then it looks like 35% of you chose, I forgot the options. Let me go back to the, okay, there we go. To switch to transdermal estradiol, and 35% to start spironolactone first because of the recent event, and then add estradiol later. So we will, review why, which one is the best option. The less preferred option was switch to parental estradiol, which is intramuscular or subcutaneous. All right, very good. Okay, so, what about this patient, right? Like, so trans woman on estrogen, and what do we know about estrogen? What do we know about cardiovascular events in transfeminine adults? Well, it is really important to recognize that when a cardiovascular event is most of the time multifactorial. We need to take into consideration the age of the patient, or the cardiovascular health status, and then or trans patients, right, like the route, not just the dose of estrogen, but also the route, the chemical nature of the estrogen that we are using, and also other risk factors, the ones that you know, right, like obesity, smoking, hypertension, and so on. All of this, right, like some of the risk factors that we know will contribute to cardiovascular events. So I will show you some of the studies that we have regarding cardiovascular events in trans women. We don't really have a lot, but we do have some. So this is a study. This is the characteristics of the patient. This is a study from Europe, in Belgium, that included 214 trans women. They also had trans men, and then they control these trans women to men and women. And so these are the characteristics. It was a pretty well match. One thing that I want you to observe here is that trans women were, it was statistically significant, the work status. They were more unemployed in the trans women group, despite no difference in the educational level, which kind of like tells you about, perhaps discrimination and challenges. That's what I wanted to show you there. So what they found in this study is that there were no venous thromboembolism or pulmonary embolism in the control group. So then that's a fact, right? Like venous thromboembolism or thromboembolic disease is increased in trans women. But then when they looked at myocardial infarction, it was increased compared to women, to cisgender women, but it was really not statistically significant compared to cisgender men. And similar with other cardiovascular events. Cerebrovascular disease, it does seem that trans women have a higher risk of type 2 diabetes. It is a trend when compared to cisgender men. So that's what it was found. Like again, it's at an N of 216, and these are observational studies, but what is worth, right? Like what this show is that the prevalence, venous thromboembolism, it is increased, but cardiovascular disease compared to men perhaps is not that different, and but it is somewhat increased compared to cisgender women. What is important here is that in this study, most transfeminine patients were on transdermal estrogen, either gel or patch, and 43% of them were on oral estradiol. So there were very few who were on, intramuscular, and there was no mention of sublingual estradiol. So this was oral. So that points to the fact that there were really not like significant cardiovascular events here. There might be because, well, the route of estrogen perhaps, so we can only speculate. When we look at the cases, well, the cardiovascular event in this study, most of them, if not all, had another risk factor. So they were either smokers, they have high cholesterol, or hypertension. So again, a lot of times is that we need to look at other risk factors as well. So this is a study in the US. This is a study, observational study in the Kaiser Permanent system. And this included more than almost 3,000 trans patients. And what they found is that they had a higher rates of venous thromboembolism. Again, I think that has been seen in many studies. And to a lesser extent, ischemic stroke relative to the corresponding rates among cisgender men and women. When it comes to myocardial infarction, it was similar to what the other study showed. It was the rates were greater compared to cisgender women, but similar to cisgender men. And this is the graph, right? Like this is myocardial infarction. This is the trans patients compared to reference men, there's no difference, slightly higher risk compared to cisgender women. So again, it's important to look at age, cardiovascular health. I show you in the studies, in the first study, where there are really very few cardiovascular events in pretty much all of them had other risk factors. The route of administration was mainly transdermal estrogen for 50%, and a lower percentage of oral and no parenteral estrogen. So perhaps, right, not just the traditional risk factors, cardiovascular health, age, smoking, and all that, but also taking into consideration the dose, the route, the chemical nature of the estrogen. And I mentioned this because when ethinyl estradiol was used before, mainly in Europe, when they have been doing trans medicine for longer than us, it was observed that patients who were using ethinyl estradiol had a higher risk of thromboembolic disease and cardiovascular disease. So we don't use ethinyl estradiol for trans medicine anymore. Right? Like it is used in oral contraceptives, but the dose is really, really low. So then the doses needed for trans medicine are higher. We cannot check levels with ethinyl estradiol. So that's the reason why it's not used. And that's why I mentioned that here. So the right answer, or the best answer for this, is to switch to transdermal estradiol. We'll talk a little bit about sublingual estradiol with the next case, right? But it seems that transdermal estradiol is the safest option when it comes to cardiovascular health. Why? So it's, it's better than oral estradiol, better than parenteral estradiol, just because of the studies that we have, especially the first one that I show you. Why not start spironolactone first as RAS-NMI and add estradiol later? That would be an option. However, the patient already had orchiectomy. So then if the patient had testes, right, then we could start with a spironolactone and reduce testosterone levels, but we are really not going to achieve much because this patient had already orchi, a bilateral. So that's why it's not the best option. And I would feel, with appropriate counseling and aggressive cardiovascular risk reduction, well, like with all the other risk factors, diabetes, hypertension, obesity, I would feel comfortable in discussion with the patient is switching to transdermal estradiol. Very good. So questions? Should we move on to the next case? All right, so we'll continue with case 2. So this is Mindy. So Mindy is a healthy 20-year-old transfeminine adult. She is on parenteral estradiol, 10 milligrams Q2 weeks. She's also on spironolactone, 200 milligrams twice a day. So it's kind of like high dose. And she's doing fine. And she was told by friends about more feminization effects with the combo of sublingual estradiol and intramuscular estradiol, as to aim for higher estrogen levels. So she's here to talk to you about that. She would like to do that because, many of her friends are doing that. Like I said, she's healthy, she's not taking any other medications, no cardiovascular risk factors, right? Like normal BMI, she doesn't smoke, no hypertension, is as healthy as one can be. So what are your recommendations? 1, add sublingual estradiol. 2, add sublingual estradiol, but reduce intramuscular estradiol. 3, advice about measuring levels of both estradiol and estrogen to assess, right? Like, because she wants that, like, I want to increase estrogen levels, or advice against such practice. What are your recommendations? Can we do a poll again?
Yeah, absolutely.
Awesome. Thank you. That's so nice, these polls.
Right, there's a few more answers trickling in here.
All right.
I'll go ahead and end the poll in about 5 seconds. Okay.
All right. So, oh, very good. So the preferred answer is C, right? Advice about measuring levels of both estradiol and estrone to assess. And then the next best, it was 29% of you said advice against such practice. Less prefer was to add sublingual estradiol, and we'll, again, review why. Which one is the best option? So what do we know about sublingual estradiol? I have to say that for a while, I was not even aware that my patients were doing sublingual estradiol, right? Like, so we are prescribing estradiol and we kind of like assume that they are just swallowing their pills. But many of my patients were actually using it sublingual, and I learned that later. So now I always ask, are you swallowing the pill, or are you, doing this sublingual melt under your tongue? So it's a good idea to always ask. So what do we know about sublingual estradiol? So this is a study, comparing oral versus sublingual administration, and it was found that is, their pharmacokinetics, pharmacodynamics are very different, even at this same dose. So what's sublingual estradiol? There is a significant peak here in, purple and blue, or whatever this color is. So there is a significant peak 1 hour after, the administration of sublingual estradiol, and then it kind of like goes down. And compared to oral estradiol, there is not such a peak, and it kind of like seems to kind of like last longer. So this might be important for when we measure levels, right? So then if you are going to measure levels, then it's probably a good idea to advise the patient, don't take your sublingual and then go to the lab and then measure an hour later, because you might get these kind of like very high levels. So then it might be a good idea to perhaps measure, after 2 hours. And this is just based on this graph, right? Like, this is not based on one. There's really no study when would be the best time to measure. But again, like we kind of like use what we have and try to apply what the little we know on how we're going to shape our practices. So when we interpret levels, it's also a good idea to find out, okay, how are they taking the estradiol? Did they take it that day? And so, like when measuring levels in your patients, it's always a good idea to guide them on how to do it, right? Like, make sure that you take your estradiol that morning, and then, go to the lab, or we'll check levels 3 hours later, or so on. Same thing with the oral estradiol. Make sure that they do take their estradiol that day for when you measure levels. So they also, this shows that this is looking at the estradiol and the estrone ratio, comparing oral with sublingual administration. So this is the oral in the lighter color, and the gray, darker color is sublingual. So you'll see that the estrone levels and the ratio is significantly higher with sublingual, right? Like, so the patient was kind of right? Like, she said that, using sublingual estradiol will increases estrone levels, and she was right. Like, that's right. So then that's what it shows. There's higher estrone levels with sublingual compared to oral. And okay, so, and then this is comparing a sublingual estradiol with transdermal or injectable preparations. Here we have, and also, patients were either taking spironolactone or not. So then the little circle is no spironolactone, and the square is with spironolactone. And you can see that estrone levels are higher with sublingual estradiol compared to the patch and compared to the injection. Not a lot of change with or without spironolactone, except for estradiol levels, are higher on spironolactone. All right, and then the ratio, right, like it's higher, the estrogen estradiol ratio is higher with sublingual estradiol compared to transdermal and injectable preparations. So what does that mean? Do we then measure levels? Like, do we want to measure estrogen and estradiol levels? She was right at saying that sublingual estradiol increases estrogen levels, but are we going to measure it? What are we going to do? Are we going to add sublingual estradiol? So this study looked at the role of estrogen in feminizing hormone treatment. And they looked at, estrogen concentrations, estradiol concentrations, the ratio as well, in transdermal estradiol users and oral estradiol users. And again, estrogen is higher in patients who are taking oral estradiol compared to transdermal. And the ratio is significantly higher. Once again, that was shown there. But then, when they looked at feminizing effects, and they looked at fat percentage, they looked at breast volume after 12 months. So estrogen concentration was indeed higher in the oral estradiol users. Again, the fat percentage and breast volume, that was not associated with estrogen concentrations in transdermal nor estradiol users. So then what this study show is that there is really no advantage of increasing estrogen levels because it won't really result in more feminization. So the change in fat percentage in breast development, they were not associated. So then based on these studies, then we have an answer to, for this patient. So then the best answer for this is advice against such practice. And when we might we showed that there is really no advantage, right, in feminization. But also there is the hypothesis that higher estrogen levels, and I don't have those studies, those are like in vitro studies, that showed that higher estrogen levels are associated with higher risk of thromboembolic disease because there are increased prothrombotic factors. So then that would be a reason not to do that, right? Like, is not adding to feminization options, and perhaps it could be harmful. Questions?
Yeah, Dr. Wright, there's one question in the chat from Becca about how do you reconcile that with folks who might be really focused on a serum number, like on a lab value? How do you?
Yes. So then I do measure estrogen levels, right? Like, I don't measure estrogen levels, but I have patients who want to measure estrogen levels, and I mentioned these studies. There is really no advantage. If they really want to check, I do, but then I might use that to actually convince them that perhaps sublingual estradiol is not a good idea, right? Like, because if estrogen levels is actually pretty high, that might not be good. That might actually be bad, right? Like, there are suggestions in vitro studies, and then also when you look at patients who are on transdermal, the patch, transdermal estrogen levels are lower, but feminization is the same. So, and then that seems to be the safest when it comes to cardiovascular disease. So then if anything, I would use those estrogen levels to convince my patient not to use sublingual estradiol. Does that help?
Great. Yeah, thank you.
All right. So we do, we need to be humble that we have a lot of limitations. Most of what we know about estrogen and cardiovascular health and disease comes from studies in postmenopausal cisgender women. And some very few studies, some of them I show you. But, like, those are limitations. We don't have like a ton of research. So, and unfortunately, what unlike research on hormone replacement therapy in cisgender populations, doing a placebo-controlled trial in trans women wouldn't be ethically acceptable. So then the evidence pertaining to the risk and benefits of hormone therapy in transgender persons must be obtained from observational studies like these studies that I show you. Okay, so then case 3. What are we doing time? Okay, so this is a 36-year-old trans female. She's on oral estradiol, 6 milligrams daily for the last 9 months. And she stopped spironolactone secondary to brain fog. She describes dysphoria with increased facial and body hair after switching to finasteride 1 milligram daily. So she would like to check testosterone levels as she feels finasteride is not helping. And she would also like to start progesterone to help with breast growth. So what are your recommendations? Add micronized progesterone after checking testosterone levels. Or add micronized progesterone, but there's no need to check T levels because, she has those symptoms. So then the level, increased hair and all that, the levels are not going to matter. Switch to a different anti-androgen after checking T levels. Or switch to a different anti-androgen, but do not check T levels. What is your, what do you think is the best choice?
Give a little bit of time for folks to answer here.
Yeah.
Right, maybe just a few more seconds. See a few more trickling in. All right.
Okay, so the preferred answer was C, like switch to a different anti-androgen after checking T levels. And the last preferred one is add micronized progesterone after checking testosterone levels. Very good. Okay, so we'll talk about this. You know about spironolactone, when is the most commonly used anti-androgen. The doses of usually 200 milligrams are pretty safe, but sometimes up to 400, have been safe if patients are able to tolerate such dose, if they're not feeling orthostatic and so on. We need to be careful, and you know this about potassium. It is really uncommon if patients have normal kidney function, but if they do have chronic kidney disease or renal insufficiency, use with caution in patients on ACE and ARBs. And also, be aware that it is a diuretic, and at times for trans women that it is an issue because they need to go to the restroom, right? Like, and that in public places, and that might not be, that might be stressful for them. So be mindful of that. It does have, some bad reputation online. I had a lot of patients who don't want to be on spironolactone anymore because they describe this brain fog. And in my experience, like, I don't really try to convince them otherwise because it's usually never effective. And we don't know, right? Like, we don't really know. Perhaps nobody has actually done a study looking at whether that might happen indeed. So then listen to your patients. If they don't want to be on spironolactone, then it's a good idea to switch. We do have other anti-androgens. We have the 5-alpha reductase inhibitors, finasteride and dutasteride. They are blockers, and this is very important to know and to talk to the patient when you start finasteride and dutasteride. It blocks 5-alpha reductase, type 2 and type 3, so then it blocks the conversion of testosterone to dihydrotestosterone, which is even stronger than testosterone. And this is relevant because then you don't want to measure testosterone levels, because testosterone levels are actually are not going to change, and because it doesn't lower testosterone levels, it just blocks the conversion. So then, and as you probably have the experience, patients are very number driven sometimes. And if you check and they see that it's high or it hasn't changed, then they are not going to like that. So then explain to the patients, we are not going to check testosterone levels because they don't change, and you explain how it works, right? Like, so the finasteride at 1 milligram, it is approved, for the anti-androgen properties. Higher doses is approved for prostatic hypertrophy. I don't think they really help, much with the anti-androgen effect. So if patients are not happy with 1 milligram daily, increasing the dose might not necessarily help much more. The dutasteride is more effective at blocking the type 1 isoenzyme, so it perhaps has better effect, when it comes to feminizing effects than finasteride. The issue sometimes is coverage, but you could, change to finasteride to dutasteride, or you could, try a different one. So again, they do. We don't need to check levels, but because they don't really block the production of testosterone, they are not as effective as spironolactone when it comes to the anti-androgen effect. So it's not surprising that this patient, after switching, notice increased facial hair and body hair. You might use that, when patients cannot tolerate a spironolactone or when they don't want to be on a spironolactone, but be aware that it's not as effective. You might use these, for partial feminization. So in non-binary patients, or we use it after an orchiectomy because, it does help with facial hair even after orchiectomy. So then sometimes we add that on, or if they are already on, we still continue it, or might want to continue it after orchiectomy. How about progesterone? So we talk about and we'll get back to the anti-androgens, right? But how about progesterone? This patient is asking about progesterone. So progesterone is also an anti-androgen. It will decrease testosterone levels. When it comes to breast development, and this patient is asking about that, right? Like, there is really not research, there is no evidence that actually progesterone helps with breast development. There are anecdotal studies, observations, and patients say that it improves areolar development. It does. I have a lot of my patients who say that it helps with mood. It has like this anti-anxiety effect. It's better to take it at night because it helps with sleep. Paradoxically, some patients feel that it helps with libido. It does. It does decrease, again, it does decrease testosterone levels. It's an anti-androgen. And if you are going to use progesterone, then the doses to use are 100 to 200 micronized progesterone at bedtime because of these sedative effects. If you are going to use progesterone, if there are no contraindications, then I recommend that you use this after the patient has been on estrogen for a while. And that is based on what we do to induce puberty. Like, again, we use, like what we know in other populations for lack of better, evidence. So when we induce puberty in Turner syndrome, for example, then estrogen is started at a low dose, is continued, but progesterone is not added until breast development is considered to be kind of like done. Right? So then, because if progesterone is added early, then it might actually compromise breast growth. So we don't want to take a chance with it, trans patients. So then I discuss this with them. I tell them, like if they had not been on estrogen for a long time and they want to add progesterone, I explain this. It's like, it might be worth waiting, because again, this is what is done in induction of puberty in Turner syndrome girls, and we don't really want to take a chance. So then that's what we do. And then avoid medroxyprogesterone because it has some adverse effects. So then the best answer for this is switch to a different anti-androgen, but do not check T levels. right? So then unlikely that we are going to get more benefit, if here, with finasteride, we could change to dutasteride, but perhaps we're not going to get that much more effect. And don't check T levels because they are going to be high and the patient is not going to be helpful at all. Yeah, so then again, these are the anti-androgens that we have, right? Like spironolactone, and these are what we, monitor, finasteride and dutasteride, and don't measure testosterone levels. How about bicalutamide? Some patients.
Right. I'm sorry to interrupt. Just one quick question that was in the chat is how long do you usually, how long is a patient on estrogen before you typically add progesterone, or does it really vary patient to patient?
I usually wait like a year, and I don't offer progesterone, but patients ask about it. And if they don't have any contraindication, and then, it is pretty potent anti-androgen, like, and it has all these other benefits in mood. And so then, but when I do use it, then I try to wait to be on estrogen for at least a year.
Thank you.
Okay, yeah, so then bicalutamide, so patients might ask you about bicalutamide, and yes, it is a very potent anti-androgen. It is sometimes used in rare forms of precocious puberty in boys. And then those, it is an anti-androgen, so then one of the side effects is gynecomastia. We need to trans patients, that's welcome most of the time. It is also advanced and metastatic prostate cancer. The doses are usually 150 milligrams daily. It is pretty potent, right? Like, so then when used in trans patients, as an anti-androgen, and this is totally off label, right? In my experience, 50 milligrams every other day is enough. Like it's you don't need to do it daily because it's pretty potent. And the precautions that you need to have with this medication is hepatotoxicity. So monitor liver function tests 3 to 4 months after starting this medication. So then the data on hepatotoxicity is from patients who had metastatic prostate cancer, and at the doses 150 milligrams daily. Right? Like at lower doses, and if patients are healthy, it is most likely safer when it comes to hepatotoxicity. But of course, you don't want to take a chance. So then you tell the patient, well, we need to monitor liver function test. So then they don't take it daily, really. So then let's just start with every other day. Most of the time, that's enough. And I explain to the patients, this is used for patients with metastatic prostate cancer. So then they are cautious, right? Like that they don't, that they are cautious, they'll take more. Or the other cautions that you will read about is cardiovascular disease and osteoporosis. But this cardiovascular disease and osteoporosis is mainly the effects of basically, severe hypogonadism, which, the effects of being really like, or no testosterone whatsoever. So then a lot of what you read about bicalutamide is in, severely hypogonadal men. So it might not necessarily apply to our trans patients. However, we need to screen and treat very aggressively cardiovascular disease and always being mindful of bone density regardless. So for your reference, I put, like in this table, the estrogen therapies that we have, the doses. I, do not use ethinylestradiol or conjugated estrogens because of their increased risk of adverse events, and we cannot monitor levels. Okay, so that's for you to have. And so then my take on estradiol in trans women is that always ask how they are taking their estrogen. And then I discuss what we know and what we don't know, right? Like I mentioned these studies, then assess benefits, risk, talk to the patients about that, and choose the safest option for patients, right? Like think about age and what we know. It's a good idea to monitor levels, and I always tell them it is good to monitor levels, estrogen levels, because we don't want the levels to, not only we don't want it to be high, but we also don't want them to be low, especially in young patients, right? Like if we are suppressing testosterone, or if the patient is after an orchiectomy, we don't really want to have low estrogen levels, because that would be detrimental to bone health, especially in a young trans woman. So then it's only not to make sure not only that it's not too high, but also to make sure that it's not low. And these patients need close follow-up, like especially at the beginning, to answer questions, to treat cardiovascular risk factors aggressively. Patients a lot of times gain weight on estrogen, so to treat all the cardiovascular risk factors aggressively, right? Like including weight gain, obesity, non-alcoholic fatty liver disease, because that. Especially because, well, that's good practice, but also because we are still not totally sure whether we are increasing cardiovascular risks or not. We are a team, and I'm always available to help you with patients and with questions. And I think we are over time, but we have time for questions, and I'm happy to answer any questions you might have.
Thank you so much, Dr. Wright. There is a question in the chat, and we have a little bit of flexibility on timing because our third session we are rescheduling to next week since Ken is on service right now. But so the question in the chat is from Lauren. And Dr. Campbell, I typically don't recommend bicalutamide given rare instances of hepatotoxicity. Of hepatic failure requiring transplant, but she does talk about Lupron, which doesn't have that risk, and was curious about kind of your thoughts on that, or just hearing more from you about that.
Yeah, so Lupron is used as well. Sometimes the barrier of that is insurance, and bicalutamide is really available. I think I'm curious, like those cases of liver failure requiring liver transplant, was that in trans patients, like in what doses?
Oh, Dr. Campbell, I think your microphone was muted there.
Yep, trying to figure out how to unmute. I believe it was in folks who were using it for prostate. And so I'm not entirely sure the dose, but I talk about it as in Lupron, we don't have that risk. And so there are risks with Lupron, much less. And with, like, I wouldn't want a single one of my trans patients to experience liver failure, need a transplant because of medications they're on. So it's not a medication that I offer or recommend for them. So even though those cases were incredibly rare, they did occur, and they weren't correlated with liver function levels in terms of testing. There was like no way to really predict for those folks who were the people who are going to end up with this. So that's the conversation I have. Of course, at VA, we have, getting Lupron approved. It's really challenging. You need prior authorizations, and even so, it's an expensive medication. But I have had I don't think anyone has taken me up on bicalutamide after those discussions because of that risk.
Yeah. So you're right. I mean, I have used it. I think that the doses that are used in patients with prostate cancer are way higher. They're 3 times higher. And, the doses that I've used in trans patients is every other day, 50 milligrams daily. So, but yes, I counsel them about that. I check, liver function test. I wouldn't do that in a patient who I might be a little afraid that they might just disappear. The patients who are normally once a year, it would be like a patient who I would be watching closely. But yes, I mean, if Lupron is an option, then that's preferred. But when it's not, I think I feel comfortable using bicalutamide in these, specific patients who I can follow closely and who are otherwise healthy, no contraindications and so on. Yep.
Interesting. Thank you.
Any other questions?
Yeah, there's another question in the chat from Dr. Shen Devon. Is there concern for spironolactone arresting breast development like progesterone? How long do we wait after starting estrogen to start Spiro?
Yes, so so then, there was a study that looked at trans women who were on spironolactone and compared to trans women who were not on spironolactone, and they looked at breast development, and it was an observational study, and they then observed that patients who were on spironolactone had more breast augmentation surgeries, suggesting that perhaps breast development was somewhat compromised by the use of spironolactone. So it was an observational study, right? But then the hypothesis is that spironolactone, it is an anti-androgen medication, right? Like it does lower testosterone levels, but it also has estrogenic properties. So it does stimulate the estrogen receptor. So then, and when we stimulate the estrogen receptor, either with high doses of estrogen, then what happens is that there is rapid breast growth, but it might stop prematurely, right? So then in induction of puberty, we start with low doses of estrogen and we slowly go up, because if we start with a high dose, then again, we might have like very robust or very evident breast growth, but it might stop soon. So then we try to kind of like mimic that in trans women, or we advise, to mimic that. And then the idea of it might not be a good idea to do estrogen and spironolactone both, because that would kind of be equivalent to high dose of estrogen, right? So then that's kind of like what we know. So we don't really want to take a chance at stopping, at not achieving as much breast growth as we could. So then I talked about that. So then we started with low dose estrogen, or I started with low dose estrogen, then add on, I increase the doses, and then maybe 6 months later, then I would add spironolactone. And usually when I explain that to the patients, they're happy with that. Now, if one of my patients were to tell me, I want to start both, I'm not against that either, because what we have, the evidence that we have is very limited, right? Like I don't have like evidence to categorically say that's not true, or that's, so then, but I discuss, like, again, I think I always discuss what we know and what we don't know, and then we make a decision. Does that answer the question? Good, thanks.
Great. Yep, there's a comment in the chat. Yep, thank you. Yes, well, why don't we go ahead and take a break now. Thank you so much, Dr. Wright. Really, really appreciate your teaching this morning. Dr. Campbell,